One more. Okay, welcome everyone to this this session on responding to deterioration with Sam and myself. We were hoping to have Alison Bowman, nurse practitioner from as she now is working for the Wodonga Palliative Care Community Palliative Care team. She was working with the East Hume Palliative Care Consultancy Unit for the beginning of this year, but unfortunately she had to absent herself yesterday, so you've got us instead. So we'll just make sure we ask you to make sure you're muted when you join the meeting, and stay muted until we ask you to answer questions, and then please tell us everything. So this is Sam Morehouse, who is the West Hume Aged and Disability Liaison Nurse. Hello. And myself, Rose Sexton, who is the East Hume Aged and Disability Liaison Nurse. If you want to know more about that, go to the Hume Regional Palliative Care Consultancy website and find out. So we have in our travels around all the aged care facilities across the Hume region, frequently get the questions about how to pick up when a resident is deteriorating. Seems to be a fairly common theme. So we decided that we would make that a topic for one of our special presentations. So really happy and grateful for you all to show up today. It's lovely to see you. I think if we can go to the next slide. So this presentation may actually not be password protected. I'm not sure.
We'll make a link and upload it, but we won't have it as a listed YouTube video. It'll only be available to people with a link, which we'll send out as an email after.
Yeah. Okay. Yeah. All right. Cool. We might start with welcome to Acknowledgement of Country. So we'll begin by acknowledging the traditional owners on the lands and waters on which we meet today. We also acknowledge that sovereignty was never ceded, and we pay our respects to elders past and present, and any First Nations people present on this call. I'm coming to you today from Yorta Yorta country, and I think, Sam, you are in Tongarong?
Yes. Sorry. I'm driving the intake as well at the same time, so
yes, I'm seeing
it takes me a second to respond.
Yeah. All right. So let's dive in, shall we?
All right.
Oh.
Sorry.
Yeah, she's having trouble.
Yeah, we have somebody having a bit of trouble getting in, which is why I'm a little distracted right now. We can
not necessarily safely say, but we make the assumption that people are familiar with Zoom. But if you're not, you can mute the mute button's down there on the bottom left, and you can turn the video off as well, right next to that button. The chat box is in the middle there. Please feel free to add chat as things are going along. If you've got a question or a comment, we love to have interaction. So that'd be really good if you can jump in at any time. So we'll start off. We thought we should go back to basics and just look at the word palliative and where that word actually comes from. So it comes from the medieval Latin palliatus, which literally means cloaked. So that is the focus of palliation, is not to try and cure or to get rid of the disease process. It's more of a covering or a cloak to shield or to sort of cushion. Yeah. So we thought we'd just, so in case someone ever asks you where that word came from, that's now you know. This is a slide that talks about all the different ways to die. And as you can see, there's not that many. There's only really 3 or 4 ways to die. When we get to aged care, we see more and more of the lower 2. But the first trajectory is you zooming along, and then all of a sudden there is some kind of acute illness, could be cancer, or one of the systems that's having difficulty, or overwhelming infection, anything. I'm sure you can think of a few different ways that blue trajectory can happen, where things are going okay, and then all of a sudden you have a fairly acute illness period, and then you die. Either you might have a terminal care phase, or you might just die suddenly. So trajectory 2 is the one that we see. If we can just make sure that you all mute yourselves again, please, that would be really great. The second trajectory is where there's maybe 1 or 2 chronic conditions in play, and there might be a hospital admission, so you go do a dip, and then you come back, but you're not quite as good as you were before, and then you're on the downward slope. You have a few acute illness episodes, and then the body is finally succumbs to that overwhelming illness. And the third trajectory is probably the one we see the most often in aged care, where it's like a frailty trajectory. So it's a gradual dwindling of all the systems in the body. There might be the occasional acute episode, but often it's just, you just see people sort of very slowly fading away. And often they're the ones that are the hardest ones to pick when you're spotting the time where they're maybe moving out of chronic, stable sort of condition into the end of life phase, or the terminal phase. Does anyone have any questions about that particular slide? You can put in the chat box, or you can unmute yourself and have a chat.
Sorry. Something also to bear in mind with this slide is it's also showing that palliative care doesn't have there isn't a distinct line in which we might take a palliative approach to care, that actually a palliative approach to care can indeed coincide with a period of active treatment, that people can be seeking active treatment and also a palliative approach, and also that palliative care does not end when somebody dies. Actually, the bereavement support is also part of palliative care as well.
Sorry, now I'm fiddling around with chat boxes and so on.
No, that's okay. There's nothing come through in the chat. Do you want me to go to the next slide, Rose?
Yes.
I think this is just a way of showing that graph, but just slightly in a slightly different way for those of us that are quite visual. So it's breaking up those trajectories of dying into those 4 different declines, with the functional status being on one axis and time being on the other. So it's just sort of demonstrating the same. So how do we recognize when somebody is deteriorating? We have tools. It's a $1 million question. There are tools. There are tools that are actually available for us to use, which is really good. So one of the most reliable and widely used tool is the SPICT tool. I've just realized my internet connection is unstable, Rose. So if I start breaking up, just feel free to take over talking over the top of me.
Yeah, you did go a little bit funny just then, but you're back again.
Oh, good. Yeah, because I don't notice when I do. So you might just have to like butt in over me and I'll get the hint. The Supportive and Palliative Care Indicators tool, which is Rose has put in the chat box so that you can download it if you want to have a look at it closely yourself. Shows a really good one-pager on how you can see really clear identifying factors around deteriorating health and functional status. Up at the top of the page, you can see some general ways in which you can identify deteriorating health. And then down the bottom, you can see they've actually divided it into different chronic and malignant diseases and what might be specific to those diseases when you're looking at recognizing people's deteriorating health as well.
So we recommend to use this tool, try and incorporate it into your resident of the day processes. I think when we're working with people day after day, and there's often a rotating roster of people coming and going, sometimes it's easy to miss deterioration when it's right in front of us, because we see the people every day. And often you'll find, I'm sure you've all got a story about someone coming back from holidays, they've been away for 4 weeks, and they get back on the floor and they say, God, what's happened to Harry? And you turn around and go, what? And then all of a sudden you have a good look at Harry and you realise, yeah, actually, when you look at, there's a few little things here and there over the past 4 weeks that have changed. And now all of a sudden, he might have lost weight, or he's sleeping a bit more, or not eating as much, or just a general decline. He's staying in bed more often, those sort of things. And so I think using this tool is it's a great way of identifying specific indicators, rather than just saying, oh, he's just off, I can't really put my finger on it. As nurses, it's not up to us to just say, I can't put my finger on it, it's just a hunch, it's a vibe. we need to have good data in front of us, especially if we're going to take our case to a doctor or a unit manager. So this gives us the data. So it does point to general indicators of deteriorating health, but it also points to specific indicators across those different systems. Now, I don't know, I hope that you have either got access to this tool. You can download it from the internet, it's very easy to get hold of, or have a look at the one that I put in the chat box. But the other value of putting and embedding that into your resident of the day activities is that you're looking at it every day. And so you start to absorb and understand they're the kind of indicators you're looking at all the time. And so in your day-to-day dealings with all of your residents, these kind of indicators are in front of mind, and it's sort of training you to be on the lookout for that sort of thing.
Absolutely.
Yeah.
The clinical frailty scale is another really useful tool which can help to articulate functional decline in particular with our residents. And we really like this too, because it actually breaks down what these arguably quite broad terms can look like for a resident. For example, somebody who is vulnerable, that vulnerable can look different to everybody, but it actually breaks it down into, while not dependent on others for daily help, often symptoms limit activities. A common complaint is being slowed up or being tired during the day. So these are just really tangible things that we can see in our residents that we can actually use to help us to work out where somebody is on the frailty scale. And also something to bear in mind with the frailty scale is possibly you're going to get more from seeing how quickly somebody changes from one score on the frailty scale to the next, because that's where the deterioration is going to be seen. If somebody was well or managing well, and then they are very quickly moving into moderately or severely frail, you are seeing a very quick deterioration, and that is how you can articulate that.
Yeah, and I think this scale is more useful in my mind than the Karnofsky scale that palliative care often uses. I think Karnofsky is great for people who were previously generally well and living in the community, but the frailty scale is a more useful tool for people who already have some pre-existing disability and lack of function or low function. It's more informative, I think.
Other assessment tools to be aware of are falls risk, pressure score risk. For families, complicated bereavement and care assessments, confusion assessments, continence assessments, and then your truly tested Karnofsky and Rupp scores, which I'm sure you're all fairly familiar with, are really good ways in which we can get a baseline on our residents and then also track changes in functional status decline with our resident health.
And these all these tools can be found on the LDAC website. I'm trying to think what the LDAC website is, but I haven't got the thing in front of me. Yeah, that's the website you need to go to. We can highly recommend it.
Sorry.
Now, I included this because of the indicators of someone entering the terminal phase. So I don't know whether you can see that, and I'll have to see if I actually I should have downloaded that as well so that I can share that with you. Yes, there it is. I don't know whether you all use the end-of-life care pathway or some form of it. If people, maybe you could put it in the chat and say whether you do use it or don't, and whether you find it helpful. I think it's very helpful. But I find those signs and symptoms associated with the terminal phase really useful, because again, it's good, strong data. It's not just, you know, a hunch or an idea, or, you know, I think you might be, but I don't know why. It gives you good data to take to, again, a manager or a doctor to say, I think this is what's happening for this resident, and it's time that we activated this care pathway, which means getting everything in place. I hear too often stories about people in aged care facilities, or staff in aged care facilities, not being able to access a doctor over the weekend to get end-of-life medications in place, for example. Or something, you know, in the middle of the night, something crops up. There's very few situations where you have emergent needs in an aged care facility. It's up to us to be vigilant and to be assessing these people, and to see when they're deteriorating, and to be able to predict that, you know, sometime in the next 2 weeks or the next 4 weeks, this person could be heading towards the terminal phase. And so let's get everything ready now, because we know it takes a couple of days. You've got to call the doctor and get them to come and see them. And then you've got to get the scripts, and then the scripts filled. Everything's got to be, you know, all the ducks have got to be lined up. So to be acting early is always the best option, because none of us want to see somebody dying a less than optimal death because we couldn't access the medications we needed, or we couldn't access the GP to put in place the things that we needed to make this person comfortable. And, you know, and then everybody loses around that.
Sorry, I drove the slides forward slightly then. It was,
Right.
We're having a couple of people having trouble
yes,
getting in. So I've been having to play with that a little bit while I've been going, and I accidentally clicked on the slides while I was trying to.
Right. Got any questions around that document or around those? Again, put something in the chat box. Thanks, Heather. I know Allura uses that. That's great. Yeah, if you have any questions or about anything in general, please chat to us.
So we've talked a little bit about what tools you can use to help recognize when someone is deteriorating, and we've talked about how the palliative approach is more broad spanning than just looking at those people in the terminal phase, which I'm pretty sure we all are aware that palliative care isn't just about those last hours or days of life anymore. It's a much broader portion of somebody's life now, and is more in tune with looking at how we live our lives and how we get the best quality out of our lives. However, it's important to differentiate that there are some changes that can be quite specific to when we're looking at when someone is entering the terminal phase. By the terminal phase, we traditionally feel that defines the last hours to days of someone's life. are typically 72 hours maximum. So here are some things that you might find that will differ slightly for somebody who's actually entering the terminal phase of their lives. Someone who might be becoming more bedbound during their deteriorating phase actually becomes ends up in bed for most of the day, to the point where they're actually unable to get out of bed or mobilize independently anymore. Increasing tiredness and weakness actually turns into sleeping most of the day, to the point where someone becomes unresponsive and is unable to communicate. Little interest in food and drink actually becomes a difficulty swallowing tablets and fluids, and the need for food and fluid depletes to the point where the person's no longer requiring it even at all. And we're looking at regular good oral care instead. Increased restlessness and confusion can turn into something that becomes more regular, or a delirium, or an agitation if we're not looking and regularly assessing it. And then other things that are new could be irregular breathing or noisy breathing, and changes in body temperature. Well, some people will experience decreased circulation to their extremities during the terminal phase, but we do need to be aware as well of what we call a hot death, or somebody who may die of a fever or an infection. They may not actually get those cool extremities that we're all looking out for, and sometimes that can take people by surprise. So just something to look out for there. So take home points from this particular portion of today's session are that when looking at someone's trajectory, when we were looking at those trajectories of illness, you can see there that actually predicting someone's prognosis is very difficult. And as a result, assessing and reassessing goals of care early and regularly becomes more and more important, as we realize that it's not something that we can predict. Care needs to be focused on the resident's family and the family's goals of care. We need to be mindful of our own values and perceptions, and how that might affect our how we approach somebody's care, because client-centered care is our goal here when we're looking at quality of life and a good death. And not doing it on our own, actually having a multidisciplinary team approach is going to increase this resident's ability to receive the best care, especially in the palliative and the terminal phase. Sorry, my little screen's blocking the way. And documentation is highly important. I mean, we can't emphasize that strongly enough. If you didn't write it, like in a court of law, it never happened. We all know that. But also it's a way of sharing information across different shifts and disciplines. We are sharing the care of somebody over a 24-hour period. And so in order to maintain our client centered care, good documentation and good care planning is going to be essential for that.
And just on that fourth point there, processes to review the resident's condition, that can be the SPIC tool, but it can also be maybe you have a trigger for getting a team meeting together, and so that as many people as possible are in on the discussion. All the people who, and particularly key players, if there's some some staff that look after this particular resident more than others, or are seen as sort of their primary, I don't know, depends on what your particular facility, how it approaches the care. But to get get the team together and have a chat about this person when it's relevant to do so, because you're going to get, it's like you all have a piece of the jigsaw puzzle, and when one of your little piece of the jigsaw doesn't tell the whole story, when you put it all together, you see a big picture and you see the person, the whole person. And then communication with the family is imperative. Again, hearing stories about difficulties with the families. And look, sometimes you're not going to be able to solve those problems, but early and regular communication with families will always, or should always, lead to better outcomes for everybody, including the staff. You know, sometimes in these days, there's a lot of people who, this is the first time they've ever had to deal with somebody who's dying, so they don't know what's going on. They're highly emotive about it, you know, feeling already guilty for putting their relative into a nursing home in the first place. And so we need to be mindful of all that stuff that's going on, as well as all the, you know, the cultural things. It's a minefield, and we're absolute super people for managing aged care. It's not an easy thing.
Absolutely. That one animated.
Yeah, very nice. So advanced care planning in aged care. Whoop.
No, you're fine.
Sam?
I actually thought time to talk was going to happen next.
Yeah, good.
Yeah, good.
Okay. No, yeah. Unfortunately, I have to leave at about 1:45. So I'm going to talk about advanced care planning. In aged care, it's a little bit different than, say, if you were someone fit and healthy or living in the community, well and independent and aging there. I like the goals of care form as a standard. Do we have that one, Sam? Yeah, okay, so.
I think it might.
No, it's all right.
There we go. Found it.
Yeah, so just go back to the slide before.
Yep.
Anyway, please.
Or yes. The one before that.
No, that one, this one.
Yep.
This is great. Yeah, so it's so useful to have these conversations early. I know a lot of facilities will have ACP as a requirement before a resident is admitted, and I think that has been seen as a little bit confronting, and we don't want to upset people. But if we keep on couching advanced care planning in terms of, you know, everybody should have one, it's just a normal thing, and it can only be a good thing because it will contribute to you getting the best care and the most appropriate care for you or for your loved one. If we keep on putting it in that way, I think that will help sort of move that process along. And it's important to stop at every step and just take a breath and say, you know, this person, the resident is developing a fever, or their lung function seems to be declining. And you take a step back and say, okay, well, let's look at the advanced care plan, see what's going on, what kind of underlying diseases they might have, what they've said about how they want their care, what direction they want their care to go in, what the family think, what the doctor thinks. Let's not just wait until there's an emergent situation and all of a sudden you're calling the ambulance and they're heading off to the emergency department in a hospital far, far away. We don't want that. Not if that's not what they want. And of course, this will require regular family meetings and regular case meetings with the team. Christine's just asked a question about staff witnessing the document. I don't think there's any issues with that. It's always ideal if you're not getting roped into that. But all you're doing is witnessing a signature. You don't have anything to say about the contents of the advanced care plan, but it's given that you're you're involved in direct care with the person, I would say, you know, avoid it, you know, whenever you can. But as far as I know, Sam, and correct me if I'm wrong, there are no specific legal requirements. What about the medical practitioner information? Not sure what you mean about that.
Do you mean, so in the advanced care plan, there are a couple of signatures we need to have in order to have a completed advanced care plan. One is evidently going to be the person who is making the plan. The other one is a treating medical practitioner. Now that needs to be a treating doctor. It should be either their GP, their geriatrician, or their medical specialist. It can't be a nurse that's signing that. And then there's the third signature, which will be the witness. Now the witness doesn't have to be a medical person at all, but it can't be someone directly related to the person filling out the advanced care plan. It needs to be like a third party. So maybe someone in the admin department of the facility. If it's a GP coming in and signing an advanced care plan in a residential aged care facility, maybe one of your admin people could do it, or someone from the domestic staff can do it. It doesn't have to be a medical person, but the medical practitioner would have to be a treating medical specialist, because there are certain assessments that they need to be making about the person in question's ability to understand what they're signing, and there might be some questions that they want to clarify around the specifics of the things written in the document before it gets signed off. So that is why we need someone who actually knows about the medical history of the person that's signing the document. Medical power of attorney, or medical treatment decision maker as it is now known, is a related document and something you come across a lot when you do advanced care planning. And it's similar and different in that that person can appoint up to, I think it's 4 people who can speak on their behalf. Both the advanced care plan and medical treatment decision maker only come into a place if that person is unable to speak for themselves. So if they sign an advanced care directive, but they're still able to speak for themselves, that overrides the advanced care directive and the medical treatment decision maker. But if at the point the person is unable to speak for themselves, then that goes into place. And with regards to the signatures with the medical treatment decision maker, you've got your person appointing, your resident, the person appointing a medical treatment decision maker. Each of the medical decision makers that they appoint needs to sign to say that they understand their responsibility and they accept the role. A medical practitioner who knows that person needs to sign it, and a witness. Oh, does it? Oh,
it doesn't have to be a medical practitioner. It's a legal document. It can be signed by a lawyer, but somebody who is authorised to sign.
That's right. You can get them. That's right. There is a list. So there's. I do apologize. Yeah, you're right. Thank you for pulling me up on that. With the information you can print out from the Public Office of Public Advocate, that there is a list of people who can sign that document. It doesn't have to be the medical, the doctor, the treating doctor, but a witness will sign that one as well. So it's the same rules for that witness. Yeah, that's right. Yeah. Another question? Office of Public Advocate. Oh, thank you.
Anyway, we do have a slideshow on advanced care planning, don't we?
We have a YouTube video on advancct care planning.
That's what I meant.
Oh, yeah. So Rose,
that's another website that you can. Sorry, I didn't put www in front of it, but
advanced care planning.
That's where you go for those 2 places. Will answer all your questions.
Yeah.
But the overall point is, get it done early, keep on revisiting the document and use it when things start to change. Keep on reassessing and checking in to say, is this still what still your goals and wishes? We're still getting it right, still on the same track, and we're all on the same page.
Yeah.
So yeah, next one. I put that into because I really like the back of this document. This is why I love the goals of care. You can do an advanced care plan, or you can gather the person's values directive and an instructional directive if there's anything specific that they know they never want, like morphine or a peg tube or intubation or being transferred to a major hospital. But this form is great because it gives chance, and it's rarely used, not used as much as it should be, for staff to write down incidental little conversations that you might be having with someone when you're walking them down the corridor to breakfast in the morning, and they just sort of say, oh God, I've had this, or, I really wouldn't care, come and take me now. Those sort of conversations that we've all had with our residents. And I think if the conversation is significant enough that it's sort of hit a light bulb in the nurse's head, then it's worth writing down. Now, this isn't sort of part of the legal document, but it still all forms this picture that goes along with the values directive, and it creates this three-dimensional image of the person when they're no longer able to speak for themselves. It gives life to who they really were and what they would choose, because that's the heart of advanced care planning focuses on when they can't speak for themselves and make a choice, the person who's been appointed to make that choice for them has to choose not what's best for them, in inverted commas, but what they think, as close to as possible to what they think that person would choose if they were able to speak. Yeah. That's the crux of advanced care planning these days.
Absolutely. And advanced care planning is a gift that a resident can give to their loved ones and family members, because it helps them to be assured that what they're doing for their loved one is what's best by them. And it really will actually help the family and the loved ones with their grief when they're reflecting on the terminal phase and the death of that person, because knowing that they've done the best that they can to honour the values and choices of that person is going to really help with that. So it's not just about the resident, it's actually also about the family as well, and the people who are caring for that person. All right.
Okay, so at this point, I've got a few more minutes, but I will just quietly leave when it's my time to go. Okay. That's my motto in life and death. I can only hope.
Did you want me to speak to this, Rose, or did you want to do this as your?
No, you can take it from here, Sam.
So we recommend that your facility establishes some kind of process, whereas you can look at your resident with fresh eyes and review them together as a team. Sometimes there can be small bits of information, like Rose says, much like a jigsaw puzzle. What individual team members hold, they don't realise the relevance until that whole picture is put together. Ooh. This poor lady's having a hard time getting on. Goals of care need to be assessed regularly, as we've discussed. And if a resident's condition deteriorates and we're using our tools to identify things that are changing, it is vital that the resident and family is giving plenty of opportunity to discuss these changes with staff. It's going to require focused time and repeated opportunities to ask these questions, and allowing for silence where questions may arise around death and dying. For those of us who joined us last week, Alison Gamble gave us a beautiful presentation on how to hold space with these conversations. And I will be submitting that recording to anyone who's subscribed to the newsletter. So be prepared. We need to make our residents feel safe and well cared for, and that sort of skill shouldn't be outsourced to a specialist. It's part of our nursing role, and in COVID times, where can we find these social workers and counsellors to come into our facilities anyway? I mean, we've all seen it. The GP has come in to have a big conversation with our residents, run into the room, given a very short statement full of medical jargon, and run out again, and just left the poor resident in a confused state of distress. And then we've had to sit with them and go through and explain to them what the conversation was actually about. So we have a duty of care to really be there for our residents, and we're probably the best placed people to actually know about how we can approach these conversations. So how do we have conversations around death and dying? So these are slightly more practical hints and tips on how we can have these conversations. So talking face to face, if at all possible, is going to make a big difference. I know these days it's often quite difficult with COVID, but it is, and if you have to, over the phone rather than a written message. Choosing quiet and comfortable places where you're not likely to be interrupted. Alison spoke to the getting caught in the corridor conversations. Try to be really mindful of trying to, of finding that safe space that you can take those family members to. So that they can have a conversation with you and not be interrupted by the phone ringing. And try not to use euphemisms like gone to sleep, kicking the bucket. You know, you can think of probably lots of euphemisms for death and dying, because that's going to be confusing and ambiguous for the resident and their family. We need to respect cultural values when we're having conversations, but we shouldn't be purposefully ambiguous for the sake of our own comfort and security. So using clear, honest language is important, especially when you're talking to somebody as well who has dementia. Using these euphemisms can cause confusion. Just a note on different cultures and religions. There can be specific attitudes towards illness and death that have create different practices accordingly. And so we just need to be very aware and mindful of cultural practices in our facility, and educate ourselves on these so that we can do what's right by our residents. And not having these conversations with our residents because we're scared of saying the wrong thing is going to be worse than accidentally doing the wrong thing, apologizing and learning from that and going ahead, going forward in a better position. When you're talking about death and dying, be honest. Pay attention to the body language of the person that you're speaking to. Sometimes somebody will not want to be a burden, will say everything's okay, but you can see quite clearly from their body language that in actual fact that they're not doing very well. So look at the person as a whole and not just what they're saying. Do stay calm when you're having the conversation, but it's okay if you do get upset. We're not robots. Getting into a state of distress where you're actually distressing the resident is evidently not recommended, but it's okay to show emotions and show that you're a human being when you're having these conversations. They're difficult conversations to have. No one is expecting us to have no emotions around these conversations, especially if you know these residents well and you've known them for a long time. Don't feel like you have to talk all the time and fill the silences. As Alison said, it's in the silences where the magic happens. And let the person know that they can talk if they need to. Sometimes you'll have these conversations and you'll feel like it's been wrapped up beautifully. And then the next day, the next hour, the next week, they may bring this conversation up again. You may feel like you're having the exact same conversation again, and you just have to exercise some patience with that, because that just might be what that resident needs at that time. There are frameworks in which you can use. There are tools for everything. There's a framework you can use if you have a conversation that you know is going to be difficult and you want to give it the best chance and give that family the best safe space that you can. Oh, thank you, Rose. A link to that has been put in the chat box for you. So if you want to structure a family meeting, for example, where you're going to have a difficult conversation, or any big conversation involving changes in plans of care, you could use this prepared framework. So some key points to take from the second half of our session this afternoon is that the more conversations we have about death and dying, the better we get at it. Practice having these conversations with each other and the people and our loved ones. Thanks, Heather. And also another good tip that I find is that if you know that there's somebody in your facility who is really good at these conversations, sit in on them when they're having the conversations, because you can learn a lot from the way that their body language, the language they use, and the way that they approach these conversations. Review your residents regularly and look out for signs of deterioration. We've given you a lot of tools that you can use to recognize signs of deterioration, and also using these tools when you're talking with your GPs, your medical specialists, geriatricians and nurse managers is going to help them to see that you've actually considered considered that person in front of you, assessed that their needs are deteriorating, and articulated in a language that is common and universal across healthcare workers. And the final key point we have today is to get familiar with advanced care planning and goals of care documentation, because the more familiar you are with it, the easier it gets to show and talk our residents through it. Every time we look at the Advanced Care Directive, we just become a little bit more familiar with it. And it's not a scary document when you get to know it, but it looks quite scary when it's the first time you see it. So if you ever get a chance, just take the time and have a little look through the paperwork. Even maybe consider filling one out for yourself if you haven't yet, because we all really should have one. I'm going to stop the recording now and open up to any questions for the last 10 minutes of the presentation.